Our next patient, Bob, had an oropharyngeal cancer that was positive for human papillomavirus, or HPV. In the United States, the incidence of HPV-related oropharyngeal cancer has dramatically increased over the past decade, surpassing the incidence of those associated with chronic alcohol and tobacco use. HPV-positive cases now account for 70% of all oropharyngeal malignancies. Public health efforts to increase Pap smear screening and HPV vaccination have already been effective in reducing the incidence of cervical cancer. Increasing HPV vaccination in both women and men can reduce the risk of oropharyngeal cancer. This is critical as HPV-positive head and neck cancer is now the most commonly diagnosed HPV-related cancer in the United States, even more common than cervical cancer. HPV-positive oropharyngeal cancers do have a better prognosis than those that are HPV-negative, but head and neck cancer survivors often go through intensive treatment and are at risk for serious long-term and late effects of treatment. Bob is a 61-year-old man diagnosed last year with HPV-positive cancer at the base of the tongue. We haven't seen him since his diagnosis. He comes in today for a follow-up visit after his chemotherapy and radiation treatment. Bob's oncology team helped him create a survivorship care plan that he brings to your appointment today. We have Bob's plans to reference throughout his appointment. Hi, Bob. I know you've been through a lot since our last visit. How are you doing?
Treatment was rough. I had weekly chemo and 7 weeks of radiation. I had a feeding tube for the last 10 days because I couldn't eat or drink enough. It took 2 months before I could even eat soft foods again. I'm slowly getting back my sense of taste, but everything tasted terrible for a long time. Even though I've been able to eat on my own for a few months, I'm still struggling to maintain my weight. Is that normal?
We see that Bob is at risk for difficulty swallowing and dry mouth on his survivor care plan. Ask Bob more about these symptoms, since they may be interfering with his ability to eat and maintain adequate caloric intake. Chewing and swallowing are complicated, coordinated processes. During treatment and in the following few weeks, inflammation and edema from radiation can make it difficult to swallow safely and efficiently. Taste changes and dry mouth impact appetite, food selection, and how long it takes to eat. These symptoms often lead patients to avoid eating with other people, which can become socially isolating. Bob, after your type of treatment, many people can't taste, chew, or swallow well. This can take several months to improve, so maintaining weight can be challenging. Let's talk about how to help you with your symptoms. By 3 months after treatment for oropharyngeal cancers, patients are typically eating a soft diet with functional taste that improves throughout the first year. If patients are struggling with symptoms, consider reaching out to radiation oncology for further guidance. Late effects of oropharyngeal radiation treatment include muscle weakness, soft tissue fibrosis, and esophageal strictures that can develop years later. If Bob develops late symptoms like dysphagia, refer him to a speech-language pathologist for a comprehensive swallowing assessment. Ordering a modified barium swallow study can localize a potential problem. To address Bob's dry mouth, we can recommend sugar-free or xylitol products, artificial saliva products, and calcium phosphate rinses. Monitor dry mouth closely because decreased saliva allows oral bacteria to produce acid, contributing to dental decay. If decayed teeth need extraction, complications from radiation, such as impaired jaw wound healing, can trigger osteoradionecrosis or bone death. Osteoradionecrosis often causes severe infection and pain that can become a chronic complication. Meticulous hygiene and close dental follow-up are crucial to prevent progression of dental disease. Ask Bob if he sees a dentist regularly and if he's had any dental issues. Patients with dental disease may require referral to a dental specialist. Let me know if these suggestions help with your dry mouth and swallowing. How's your energy?
Well, I'm tired a lot. My treatment ended 6 months ago, and I guess I thought I'd feel better by now. Is there a reason I'm still so tired?
Bob's fatigue could be from hypothyroidism. The radiation field for oropharyngeal cancers, particularly of the larynx or hypopharynx, often involves the thyroid. Radiation-induced hypothyroidism develops in 25 to 50% of survivors like Bob, typically over 6 months to 5 years after treatment. There are no screening guidelines for radiation-induced hypothyroidism, but testing an annual thyroid-stimulating hormone, or TSH, is recommended for the first 5 years after treatment. Educate Bob about the signs and symptoms of hypothyroidism. Consider depression as a cause for Bob's fatigue. The risk of depression, anxiety, and post-traumatic stress disorder is significantly higher in cancer survivors. Please be aware that head and neck cancer survivors are also at much higher risk for suicide, 3 times greater than the general population. It is important to assess for depression and anxiety routinely in all cancer survivors. Just ask Bob, "You've been through a lot recently. How is your mood?" Listen to Bob. Let him share his experience. We can counsel Bob further. If you frequently feel down, hopeless, or have little interest in doing things, please reach out to me. I'm always happy to talk. We can find ways to help you together.
Thanks. That means a lot.
Bob may be a man of few words, but simple interactions like this can reassure patients that they are not alone. Bob is not a smoker and limits his alcohol consumption, but remember that screening for modifiable risk factors like smoking and excess alcohol intake is particularly important in survivors given their risk for late effects and secondary cancers. Tumors of the oropharynx often affect speech, swallowing, and breathing, so head and neck cancer patients need a robust, multidisciplinary care team and a strong quarterback, you, their primary care physician. As primary care physicians, we play a central role in coordinating care for all our cancer survivors. Here are some points that I have found helpful. When reaching out to specialists, keep questions specific so responses may be both direct and actionable. Ask about the schedule for follow-up and surveillance, including clinic visits, labs, and imaging. Ask for guidance on long-term and late effects of treatment and prognosis. This will help you provide specific anticipatory guidance about treatment effects and tailored management of comorbidities and age-related screenings. Bob may have been waiting for his next appointment with his specialists months later to discuss his symptoms instead of alerting them promptly. Your effort in care coordination matters. Patients really appreciate when we can communicate with each other. Bob's case demonstrates that HPV infection is an increasingly common cause of head and neck cancer. Head and neck radiation can lead to dysphagia as both an acute and late effect. Cancer survivors have increased risk of depression and anxiety. Screen routinely for mood disorders. Fatigue may be an indication of hypothyroidism as a late effect of neck radiation. And communicating with the patient's cancer care team can be helpful for you and your patients. This concludes the second case. Please advance to the third case.